Please sit down. It's my great pleasure to welcome you to this Royal College of Surgeons of England Kinmonth Lecture. This is a great tradition going back a long time. Indeed, one of the great attractions for me to come into vascular surgery was the fact that we seem to have an enthusiastic culture of research and evidence base. Over the years, many people have contributed to the knowledge that we have about vascular surgery, not just vascular surgeons, but anaesthetists, neurologists, and many others. Some of those have been fortunate enough, or we've been fortunate enough to listen to them to summarize their contribution to vascular surgery. Today's lecturer, Peter, who needs no introduction, was actually an Edinburgh graduate, qualified in 1987, and in 1996 he became the Oxford lecturer in neurology. He became an MRC senior fellow and subsequently a chair in Oxford. He's made a huge contribution. He has something like 300 published papers, but many of those have been relevant to vascular surgery and in particular to carotid surgery. So it's my pleasure to invite Peter Rothwell to come up and give today's Kinmonth Lecture on carotid interventions, past, present and future. Peter.
Thank you very much, Mike. That's a very kind introduction, and it's a great honour for me to give this lecture, which is in fact the 30th Kinmonth Lecture, and it's an impressive experience looking back at the previous 29 lecturers, some of which have focused on carotid disease, including Professor Sir Peter Morris, who supported me when I first went to Oxford. The Kinmonth Lecture is named after John Kinmonth, as you know, as vascular surgeons, a pioneer vascular surgeon from St Thomas's, who had many interests and was from that generation of surgeons who seemed to me to be sort of inventing it as they went along, using old Terraline shirts to make arterial grafts, for example, but was most famous for his work on the lymphatics. And it's rare actually to find a book that's 40 years old but which is still referenced fairly frequently, as his treatise on the lymphatics is. Now, Ross Naylor, your ex-president, gave me the title, and as I said, I always do what Ross says. So the title is Carotid Interventions, Past, Present and Future. In declining order of certainty, we know a little bit about the past. We know virtually nothing about the present, really, and we know absolutely nothing about the future. So I'm going to concentrate mostly on the past, because I think there are some useful lessons to learn that apply to the future, and say a little bit about one or two issues that relate to the future that I hope we haven't done to death completely in the last hour. The past, the very early days, and you'll know this as vascular surgeons, the pathophysiology of carotid disease began to be elucidated in the 19th century. And the interesting thing for me, looking at that list, is that all these people did other things. And it's very interesting, isn't it? Great people are never one-hit wonders. Virchow, Chiari, Miller-Fisher, they did many different things. In terms of the intervention itself, all the early work was carotid ligation, with some fairly high-risk outcomes. I'm not sure what Dr. Foster would think about 41% mortality these days, but there were some case mix issues, and some of these people were being operated for post-traumatic carotid injury, etc. So it's difficult to do well with that. In terms of the names there's one person I'd like to mention in particular, because I'm a neurologist, and the subject of this talk really is the partnership between neurologists and vascular surgeons, and actually the partnership between Canadians and British researchers, which has been at the heart of the development of carotid interventions. This is C. Miller Fisher, who's one of the grandfathers of neurology, really, who died this year. And as I mentioned, he was important in reinventing Chiari's idea that embolism from carotid stenosis was a cause of stroke. But he also discovered a variant of Guillain-Barré syndrome, popularized the concept of TIA, explained lacuna stroke, realized that atrial fibrillation was a cause of stroke, and then understood carotid and vertebral artery dissection, which is an amazing list of achievements for one man. The early days, in terms of the first operation, you know all this, there's great debate about who did the first endarterectomy, but I think the operation that popularized it, and we regard as the first, is Felix Eastcott's operation in May 1954. The St Mary's man, and a few days later another St Mary's man, Sir Roger Bannister, neurologist of course, ran the first 4-minute mile. So it was an impressive week for St Mary's in 1954. That's a picture of the first operation, which I'm sure you've all seen many times before, and an interesting quote there from Felix Eastcott himself many years later. The other great neurologist in the story is Henry Barnett. And this is Henry Barnett at about the same time in the 50s at Toronto General Hospital. Barney, as he's known, was really the foremost trialist in vascular neurology, and critical to the whole story of how endarterectomy developed and was studied. He did the ECIC bypass trial and had an incredibly hard time from the community in the US for proving that ECIC bypass didn't work. He did the first ever randomised trial of aspirin in prevention of stroke, and then was responsible for the NASIT trial. Very impressive individual. And in fact, Barney came to visit us in Oxford a couple of years ago, and we took him to visit Felix Eastcott, who just before he died, who lived quite close to Oxford, and that was a nice occasion that the two met each other. Interestingly, as I say, there's the Canadian and the British link. Interestingly, Felix Eastcott was actually Canadian. He was born in Montreal, moved to the UK at the age of 3. People say that's probably long enough for Canada. Someone once cruelly said that Canada's a great place, but not for a whole weekend, which I think is slightly unfair. But Felix stayed for 3 years. Barney, in fact, was born in Newcastle in the north of England. He's actually British, and then moved to Canada at about the same age. There's an interesting story, actually. Probably the three foremost neurologists, certainly in this part of the world. A few years ago, Henry Barnett, Lord Walton, John Walton from Newcastle, and Brian Matthews, who was the first chair of neurology in Oxford, were all born within 3 months of each other in Newcastle, and never met until they became eminent neurologists. And they're also all sons of vicars. So 3 sons of vicars, all born within a few months of each other, within a few miles of each other in Newcastle. I think it's too much of a coincidence, but these things happen. So where were we in the 1970s? And you're familiar with this sort of description of people's opinions. At that time, there was the aggressive American, usually vascular surgeon, who thought that all patients benefited from endarterectomy, irrespective of stenosis. There are just sort of rather nihilistic British neurologists that really wasn't sure up here and was very opposed down here. More enthusiastic neurologist, and the typical British vascular surgeon who was perhaps persuaded up here but uncertain down here. And of course people got together to do trials eventually, and did that very effectively because of the uncertainty and the different levels of uncertainty and different uncertainties at different degrees of stenosis. It ended up working very well. But there was a lot of criticism at the time about the fact that there weren't any trials, and this is an overused quote from Dave Sackett, that as in other branches of medicine, surgical studies with controls tend to lack enthusiasm, and surgical studies with enthusiasm tend to lack controls. And that applies to all areas of medicine. But there was an attitude at that time that the enormous numbers of endarterectomies being done, particularly in the US, was on the basis of no good evidence at that time and was just on the basis of surgical case series before and after studies, as it were. And people became increasingly critical for various reasons. There was a realization that before and after studies aren't always convincing evidence. This is one that I found in one of my wife's magazines when we were visiting Canada, actually. This is what apple cider vinegar gel caps do for you. Apparently this is fine from a journalistic point of view. It doesn't contravene any rules because they don't say it's the same person before and afterwards. It's only the reader that kind of assumes that. But as long as it's someone before and someone after, it's fine. So that's the sort of level of evidence that sometimes we're dealing with in medicine, but not in vascular surgery, thankfully, most of the time. But people were beginning to realise in the 70s that what seemed like a good idea wasn't always a good idea. And we got our fingers burnt so many times by doing things that seemed obvious. So, and you're familiar with these examples, I'm sure, but it's worth repeating them, I think, for the juniors. High-dose oxygen in therapy in neonates with respiratory distress syndrome after birth. It makes such obvious sense. They're in respiratory distress, they need high-dose oxygen. But of course it was found to cause retrolateral fibroplasia, and 50,000, mainly North Americans, were rendered blind by high-dose oxygen at birth, including Stevie Wonder, in fact, one of those. Antiarrhythmic drugs post-MI. Post-MI there's a high risk of transient ventricular arrhythmias, and those arrhythmias themselves predict a high risk of sudden death over the next few months or years. So if you've got a drug that stops the arrhythmias, of course it makes perfect sense to give it long-term post-MI to reduce the risk of sudden death. And people did that for over a decade until someone did a trial and showed that it increased the risk of sudden death by a factor of 4. And more North Americans were killed by flecainide than were killed in Vietnam at about the same time. And there's a long, long list. The worst one, I think, is probably sleep imposition in babies. The medical profession advised for decades, as you know, that we sleep babies on their tummies because sudden infant death syndrome is caused by vomiting and swallowing the vomit, and in fact it turns out that that probably doubles the risk of sudden infant death syndrome. So we can get it wrong. In fact, to err is human, but to really mess it up takes a doctor, I think, is probably not a bad maxim to bear in mind. So we do need trials, because things that seem to make sense often don't. And there was also criticism at that time, as Mike Goff's alluded to, and it's still there now, that the operative risks seemed to vary enormously in different surgical case series, and people began to scrutinise these a lot in the 80s and early 90s. And as Mike showed, there's often, when you look, a lot of heterogeneity. And people noticed that it seemed to depend on who was reporting them. If you looked at studies where surgeons were reporting their own results, then they were often pretty good. And if you looked at studies that included neurologists doing independent assessment, they were often much, much worse. And this is probably publication bias to a significant extent, but it shows the fact that there was uncertainty about what the true risk was of endarterectomy, and there was uncertainty, therefore, about benefit, whether the benefit outweighed the risks. One tip, which I'm sure you're all aware about with carotid surgery, is that the case fatality, the proportion of operative strokes that kill you, is always about 20% in all large studies, all large trials. It's the same for stroke in general. So if you've got a surgical case series where there's an 80% case fatality, only a 2% risk of stroke, but they're nearly all fatal, you know that's not true, and it's based on big numbers like 2,000. If you look at the large trials, they all cluster around, for symptomatic stenosis in those days, a 6 or 7% risk of stroke and a case fatality of about 20%. And so essentially you can just adjust those operative risks up to the right case fatality, and you get a risk of a stroke which is exactly in the cluster with the rest. So you can do something about this, but it's still there. Most of the reports with very low risks of stroke, they're all fatal, because you can't miss the deaths, but you can miss the minor strokes. And I'll come back to minor strokes in a minute. There were some randomised trials in the early 70s. Another Canadian neurologist, Bill Fields was the force behind the first randomised trial in the US, the Joint study, which was a small study, and it was complicated by a lot of different indications, but nevertheless it did provide some evidence. And then Prof. Shaw, a neurologist in Newcastle, with colleagues in Newcastle, did a subsequent small study that was stopped because of a high operative mortality. And this is one of the very first meta-analyses done by Richard Peto and co. in the early 80s, showing that there's still a lot of uncertainty, not surprisingly, about the balance of risk and benefit of endarterectomy at that time. And so in the early 80s, a lot of people were becoming increasingly concerned. There wasn't good evidence that this procedure was beneficial. There were at least 100,000 operations per year in the US. And so a number of individuals got together when Henry Barnett was the editor of Stroke, the leading vascular neurology journal, including Charles Warlow, and wrote a whole host of articles and started criticising the procedure, saying we need evidence. And I think it's remarkable when you look back at the impact that had. I mean, these were clearly serious people having an impact, in that the rapidly rising rate of endarterectomies actually reversed and went down for several years on the basis of these opinions being expressed and the trials getting going. And I think it's hard to imagine that perhaps happening nowadays. It's more difficult to change medical practice, but just that expression of concern did have an impressive impact. Charles Warlow had started randomising patients with surgical colleagues in 1981 in the European carotid surgery trial, and Barney started randomising in NASIT in 1987. It's interesting, Barney was on the data monitoring committee of the UCST, and I can't help thinking he could see a result emerging and therefore dashed off to start NASIT, having had the failure of the ECIC bypass trial, but I think that would be entirely forgivable in the circumstances. So we had these two big trials ongoing, and there was the VA trial as well that started shortly afterwards. And the nice thing was, as a collaboration between neurologists and surgeons who had different areas of uncertainty, patients were randomised right across the range of stenosis. As you'll recall, some patients with 20% stenosis at the bifurcation, so just a little bit of plaque in the carotid bulb, really, all the way up to severe stenosis. And these were the patients randomised by Charles Warlow and Peter Morris in Oxford in the UCST at that time. And it shows the range of uncertainty in those days about who should be operated. When the first results reported in the early 90s, at least the European trial, it did clarify things. There was no benefit from surgery, certainly up to about 60 or 70% ECST stenosis, but quite substantial benefit above 80% stenosis, and uncertainty in between. And so the degree of uncertainty had been dramatically reduced by that one pivotal trial. And that had an impact, as you'd expect. The NASIT trial reported on the same day the same results, benefit for severe stenosis in 1991. And certainly in Oxford, Peter Morris and then other colleagues, obviously since, Jack and Linda and the rest of the team, suddenly started doing more endarterectomies. The numbers then dropped a little bit after the moderate stenosis result, and then have gone up again since and carried on going up. So I think it's a wonderful example of teamwork between neurologists and vascular surgeons to gather the evidence, and then an impressive recognition by clinicians of the impact of the evidence. What we did, or what you did, was driven by the evidence that was emerging, and I think that's incredibly impressive. So at the end of the 20th century, we had these two big trials with seemingly slightly different results. The NASIT trial suggested that surgery was beneficial above 50% stenosis, the ECST above 80% stenosis, and in fact only above 90% stenosis in women. So there was that confusing issue, and we had no reliable data on angiographic, clinical or pathological subgroups as to who might benefit most from this dangerous procedure that needs a degree of targeting, as we've heard already. And so the data were put together in the carotid endarterectomy trialist collaboration that I was privileged to be part of. And we ended up with quite a lot of statistical power. There were 35,000 patient years of follow-up and a lot of strokes during that period that allowed people to look at the effects of particular characteristics. And that was partly because the trials had taken so long to do, but in some ways that was fortunate at the end. And it allowed us to focus the results a little bit more clearly and draw out some further conclusions. One of the nicest things was how the European trial and the American trial were almost identical. The ECST cost £1 million and NASIC cost $100 million. And it shows that you can do things in the NHS and in the UK healthcare system and with European colleagues much more cheaply and effectively than they can in the US, and actually get the same results. This is severe stenosis, obviously surgery, medical treatment, ECST, NASIT works slightly better in Europe actually, and the same result for moderate stenosis, when stenosis is measured in the same way by the NASIT method. So redefining the outcomes to be identical, remeasuring the angiograms gave virtually identical results. And so the data could then be pooled quite reasonably without fear of too many biases. And that gave power then to define the benefit in patients with moderate stenosis. So there is some benefit from endarterectomy for moderate stenosis. It takes a couple of years to kick in, but it's about as effective as good medical treatments are, 10% absolute risk reduction, eventually after 10 years follow-up. And so worth doing, particularly, as you said earlier, if it's done quickly and early. Benefit for severe stenosis was substantial, as we've just seen. One point that's worth bearing in mind, and it does relate to the conversations we were having just in the previous session, is that endarterectomy or stenting versus medical treatment, if there were any trials of stenting versus medical treatment, mainly prevents non-disabling stroke. It mainly prevents minor stroke. There is an effect on disabling stroke, but it's a lot smaller than the effect on all stroke, and there's no effect on death or fatal stroke. So the argument that stenting, the excess risk of stenting, is only minor strokes, therefore we don't need to worry about them, even if we're not concerned about the associated risks of dementia, fatigue, depression, and all the other very debilitating consequences of minor stroke. Even if we're not worried about those, we still have to remember that these procedures are mainly only preventing minor stroke to begin with. And so the fact that the increased risk with stenting is only minor strokes actually gets you no points at all, because that's mainly what you're trying to prevent. So it isn't an argument, really. The other useful thing that was found was that the near occlusions that people had thought were high risk actually tend to be relatively low risk. People used to worry a lot about these patients. They're about to occlude. They'd sometimes be rushed into hospital, heparinized, and then operated quickly. And it turns out that, in fact, this is a very low-risk scenario. And the reason it's low risk is because these patients always have good collateral flow. I looked at thousands of angiograms of these patients, and I didn't find one who didn't have good collateral flow from the opposite carotid. They're perfusing the symptomatic hemisphere from the other carotid. They always have anterior communicators. There was only one patient with this appearance of a near occlusion who had an occluded carotid on the other side, which was about an odds ratio of about 50 compared to patients without near occlusion. So in fact there's very little blood going through, there's no potential to embolize, and they're hemodynamically reasonably well off anyway, which explains partly, I think, why surgery isn't beneficial in these patients. They have a relatively low risk of recurrent stroke on medical treatment, and so the surgical treatment doesn't really add to that. And whichever outcome you look at, ipsilateral ischemic stroke, benefit increasing with stenosis, no benefit in near occlusions, any stroke or death, or disabling stroke or death, nearly harm for disabling stroke or death. Interestingly, they do have recurrent TIAs. The patients with near occlusions do come back with recurrent TIAs, and surgery does prevent those, but it doesn't prevent recurrent stroke, as far as one could tell. You could then look at subgroups, as I mentioned, and there were some statistically significant subgroup treatment effect interactions from the trials. Endarterectomy was of greater benefit in men than women. Benefit increased with age, decreased with time, as we know, was greater for stroke than for TIA, greater for cerebral events than for ocular events, greater for irregular ulcerated plaque than for smooth plaque. And there's probably no other medical treatment I can think of where there's so much information on who benefits and who doesn't, because there were two large trials and the subgroup effects were identical in both. So it's a strange situation. We know more about the the risks and benefits of this procedure than virtually any other. And you can then do risk models. You can say, okay, well, if this procedure is driven mainly by, the benefits driven mainly by the risk of stroke on medical treatment, let's predict the 5-year risk of stroke and see what the benefit is in the high-risk people versus the low-risk people. And it works reasonably well. You can validate these sorts of models. This was a validation of a model derived on the European trial, tested on the North American trial, and this is just quintiles of 5-year risk on medical treatment. Some patients are low risk despite having a severe stenosis, and some patients are very high risk, obviously. And you can individualize that to some extent, and you get to the situation which is really the holy grail for risk prediction of risks of greater than 50%. You're more likely than not to have a stroke over the next few years with your severe stenosis, down to less than 10%. You've got an ocular event, you're under 65, it was 3 months ago, the risk of stroke over the next 5 years is less than 10%, so you really can't benefit from endarterectomy. And this model's available on our website, and it's had about 50,000 uses over the last few years. So some people do try and individualize the treatment in this way, but even if you don't use that, you can use the subgroup analyses as some evidence. Local anesthesia was a big question a few years ago, as Mike Goff alluded to, and as Mike Horrocks has also contributed greatly to. There was a lot of non-randomized evidence, and it's another lesson about non-randomized studies that suggested that it was a no-brainer. Endarterectomy under local was so much safer than endarterectomy under general. The mortality was lower, 50% lower stroke risk, MI, pulmonary complications, they were all less. There was a small amount of randomized evidence, 6 tiny trials, but even those were encouraging. There were 6 deaths in the general anaesthetic group versus 1 death in the local anaesthetic group, so it was going the same way as the non-randomized data. And then Mike did the Gala trial with Charles Warlow, and I came along to the meetings but didn't do much else, and showed in fact that wasn't the case. The patients preferred local anaesthetic, but in fact the risks were about the same, the operative risk of death, the operative risk of stroke. There were some small benefits, but it wasn't what the non-randomized data had suggested. So local anaesthetic has caught on, I think, in many centres nevertheless, and the patients do seem to prefer it. If they need reoperation, they tend to opt for local again. So that's the past. The present we've really discussed already, so I'm not going to say much about that, other than just to mention the analysis I mentioned earlier, which is to look at the results of the ECST trial, the European trial. If it hadn't gone beyond the UK, for the first 5 years it was just based in the UK vascular surgeons, UK neurologists, and recruitment was slow, and so it expanded into European centres, Netherlands, Germany, France, and other centres. And if you look at it by which centres got patients in quickly, which centres got them in slowly, just above and below the median time from event to randomisation, then you find that all the European centres nearly are fast centres, and nearly all the UK centres were slow centres. And so if ECST had been done in the UK, it would have shown significant harm nearly for moderate stenosis and no benefit for severe stenosis. If it had been done in Europe, rather like NASIT was in North America, where patients were seen quickly, then some benefit for moderate and enormous benefit for severe. So we could have got a very different result in those days by the process of care being slower than it is now and slower than it was in Europe. So it's a good lesson in the external validity of trials. You can't always apply trial results from one healthcare system to another, or you've got to be careful in doing so. Imaging we've heard about, and clearly that is going to change what we do with patients, and it's certainly changing at the moment. It has changed our management. My group's mainly an epidemiology group, but we've been forced to write papers on imaging over the last few years because it is so important to what we do in terms of DWI, identifying acute lesions, gradient echo, identifying microbleeds, and as Hughes talked about, non-invasive imaging, identifying stenoses so that we can stent these patients with severe disease. And the imaging is continuing to move ahead at pace. We're doing quite a lot of work at the moment with ASL perfusion mapping, looking at the territory of strokes and TIAs and mapping which arterial source they're fed by, and we're looking at various BOLD techniques as well. My hunch is that actually none of these are going to turn out to be clinically useful. Functional imaging hasn't yet shown as many clinical uses, and I don't think it probably will in the next few years. But they're certainly fascinating and they're interesting to do research on, but I don't predict they're going to change the world. We've heard already about plaque imaging, and I think that clearly is important, and it is going to slowly get into clinical practice. I suspect it probably will, as we've heard, be more ultrasound, or at least more update ultrasound than this, and less MR and CT. Because I think the problem with MR is to get sufficient resolution, you need about a 4-hour scan with special net coils, and it really is tough to get high quality images from MR, and you can get them much more quickly from ultrasound. And one of the problems is the resolution yet just isn't good enough to pick up thin fibrous caps. It's a study we did in Oxford looking at 500 symptomatic plaques and just looking at the cap thickness that was associated with rupture. And it's only when you get down to a cap thickness of about 200 microns that you get a substantial increase in rupture, risk of rupture, as it were. And the imaging, at least MR imaging and CT imaging, still isn't at that degree of resolution, even with imaging sessions of longer than an hour. So I think it's a good while before, for some parameters, we'll have good non-invasive imaging. So the future, in the last 10 minutes, I'll just say a little bit about these 4 issues, and I'll skip over some elements because they've been covered already. Age, I think we've talked about a little bit, but I think we underestimate what an enormous impact it's going to have on us as clinicians. As you know, for the last 4 decades, human life expectancy has been extending at 6 hours per day. It's an incredible rate of lengthening, as it were. And this is the prediction we got from our data a few years ago on the increase in incidence of stroke at different ages. And as you can see, the vast majority of the increase in incidence by 2050, even before then, is going to be at the age of over 85. At the moment, the mean age of TIA or stroke in our population is 75. In about 15 years, it's going to be over 80. And by 2050, it's going to be over 85. So anything that doesn't work well in the elderly is not going to be clinically relevant unless it can be made to work well in the elderly. Now, the nice thing about endarterectomy is that it does work well in the elderly. All of the systematic reviews that have been done of surgical case series show that the operative risk of stroke doesn't increase with age. There's a small increase in the risk of operative death, mainly due to coronary events, which does increase slowly with age, but it's small. But the stroke risk doesn't. And when you go back to the subgroup analyses in the old trials, at least in the 90s, the benefit of surgery, this is benefit, this is harm, increased with age because the risk of stroke on medical treatment increased with age. So for those patients that got into the trials over 75, they got a lot more benefit. So endarterectomy with older age groups is good, but we know that that's not the case, as we've heard already, for stenting. The systematic reviews show that. The randomised trials show that, stenting versus endarterectomy. Stenting performs much worse in the older ages, and that seems to be pretty much a continuous association. So when you get over 80, and bear in mind in a few years people are all going to be over here, so this is going to be perhaps a 3-fold excess risk with stenting unless things can be improved. And there's going to be virtually nobody down here in a few years, very few endarterectomies under 60. So it is going to change that balance, and less stenting can be made safer in the elderly. And the CREST trial found the same result, as you know. I'll just show this picture of Bob Hobson, who really was the driver behind the CREST trial and sadly died prematurely a few years before it finished. And I think the way that CREST has been handled and interpreted and pushed would actually have been very different if it had been Bob Hobson in charge at the end. But we are where we are. And they do it the other way around. Stenting is safer in younger people, but this is where the statistical power is actually in the elderly in narrow confidence intervals. Endarterectomy, much safer in the elderly, even in CREST. And you find that if you look at the plaques themselves, of course, as you know, you take them out. They're much more calcified in the elderly. If you look at younger patients, 27% heavily calcified, 61% heavily calcified in the over 75s. So it might well just be the nature of the plaque. But there is a problem which needs to be overcome for stenting if it's going to be of wide clinical relevance. The other problem is ageism in ourselves, not in you, but mainly in neurologists. We don't like old people in neurology. Most of my colleagues don't like to see the elderly. Most neurology dementia clinics have an age limit of about 40. But anyway. And they also don't investigate patients with carotid imaging once they get to about 70. This is our data for our study. This was the rest of Oxfordshire in a study that Jack Fairhead did, one of our vascular fellows. So you don't get investigated if you're over 80, and not surprisingly, there seems to be a low incidence of stenosis when you're over 80 unless you investigate people when there's a high incidence of stenosis. So the disease is there in the elderly, and of course you're all used to treating it now. Selection of patients for CAS, we've talked about already, and I'll just touch on this very briefly. We know about the trials, we know about the overall results for stroke. CREST found exactly the same for stroke. And it's the same for disabling stroke, which is important to remember. The excess is still there for disabling stroke, and it was there for disabling stroke in CREST. One of the issues, therefore, as we've talked about already, is where the complementarity is. Which groups of people or which individuals might have equivalence between endarterectomy and stenting. And you can look at this by just looking at the predictors of operative outcome with stenting and the predictors of operative outcome with endarterectomy, and you can compare them. And as people have intimated, we've been doing these incredibly tedious, both to do and to read, systematic reviews for years of the predictors of operative risk for endarterectomy. And we combined these with Emmanuel Touzé in Paris, who's been doing the same for stenting. And in fact, it is interesting. There are, and they're the ones that you would expect, there are definite statistically significant differences between the predictors of operative stroke with stenting and the predictors of operative stroke with endarterectomy. We've talked about age already. If you do the systematic reviews, this is 237 studies, the world literature. Age is more of a risk factor for CAS. This excludes all the trial data than it is for endarterectomy. Contralateral occlusion, you won't be surprised, not a risk factor for CAS, but it is a risk factor for endarterectomy. Female sex tend to do somewhat, male sex tend to do somewhat better with CAS than with, or with endarterectomy than with CAS. Women tend to do slightly worse with endarterectomy. And of course, restenosis, not a major problem for stenting, but much more a problem for endarterectomy. So you can create a rule, you can call it the SCAR rule. If you're SCAR positive, then you need a SCAR on your neck, not your groin. So if you're female, under 75, contralateral occlusion, restenosis, then stenting might be reasonable. And then you can validate that on the trial data, as Emmanuel Touzé did. And it turns out it works reasonably well in the European trials. These are people who are SCAR negative. The endarterectomy and stenting are roughly equivalent. And these are people who are SCAR positive. The risk of procedural stroke with stenting is about 2.5 times higher than with endarterectomy. The main point is these are about 20% of the patients, and these are about 80% of the patients. But nevertheless, there is a group who you can legitimately say probably do as well with stenting as with endarterectomy. Antiplatelet treatment we've talked about, and just very briefly, I'll say a couple of things about this. One of the most surprising things that we found with our studies of TIA and minor stroke is how acutely preventable the early risk seems to be. If you take these patients and you give them immediate aspirin with clopidogrel if they're high risk, lower their blood pressure, give them a statin, you can reduce the acute risk of stroke by about 80%. In fact, on long-term follow-up, the lines come more together. But acutely, these events are exquisitely preventable. And it's not really clear why that, or it wasn't clear why that was. It doesn't seem to be statins, probably. The randomised evidence isn't that impressive for acute use of statins and stroke. It probably isn't blood pressure lowering. And so you're really left with antiplatelet drugs. But the problem is, we know that the secondary prevention trials with aspirin only showed a reduction in stroke risk of about 10 to 15% over the next few years. So aspirin on its own couldn't explain this 80% reduction in stroke risk. But in fact, if you go back to the individual patient data, which we did recently of the early trials of aspirin versus placebo, it turns out that there is a much, much bigger benefit acutely in the first 90 days. There's about a 60% reduction in the 90-day risk of ischemic stroke on aspirin versus placebo in these TIA or minor stroke patients. And in fact, the benefit almost disappears then. So this 10% reduction, 15% reduction at 3 years is all acute and then more or less disappears. So in fact, most of what we found was probably a benefit of aspirin. And when you add in the additional possible benefit of clopidogrel, then you get to about 80%. What was most interesting was if you look at disabling stroke, not just any stroke, aspirin alone reduced the risk of recurrence at 90 days by about 75%. So just giving aspirin is incredibly effective for that initial period, and I think there's enormous public health relevance of that. Anyone with a suspected event should take an aspirin immediately, no matter what it turns out to be eventually. It's probably going to be beneficial. We've heard already about clopidogrel, and so I won't labour this, and Hugh Marcus's trial Caress was very influential in showing the effect on microemboli, and there is suggestive data that adding clopidogrel to aspirin from other studies is probably going to be effective. The Chance trial will report in about 2 months' time now with several thousand patients from China with aspirin plus clopidogrel versus aspirin alone, and I think we'll settle the argument. But I suspect we're going to have to give these patients, I'd be surprised if it's not positive, we have to give them clopidogrel as well as aspirin because the benefits, I suspect, are going to be there. And I think we just have to think about how we can cope with that from a surgical point of view. Ross Naylor can cope with it fairly well, it seems, and so if Ross can do it, presumably the rest of you could do it fairly easily. I get myself in trouble. But you mustn't stop aspirin. We probably need to stop clopidogrel rather than stopping aspirin. The current NICE guidelines say use clopidogrel long term, but they ignore the other benefits of aspirin, as we found a little while ago for prevention of cancer. If you follow up some of these trials long term, you also get enormous reductions in the risk of dying of some cancers, esophageal, colorectal, lung, and some others. So we're only beginning to scratch the surface of what aspirin does, despite the fact that it was invented in 1895 and is the world's first ever pharmaceutical. We're only beginning to understand what it does. It also reduces the risk of metastasis if you've got a cancer already. Metastases are mediated by platelets when they're in the arterial system, and aspirin substantially reduces the risk of blood-borne metastasis. And we're now doing trials of aspirin in treatment of cancer to try and see whether it works if you start it after the cancer's been diagnosed. Finally, asymptomatic stenosis, I'll skip over very, very briefly so I can finish on time. We've talked about this already, really, so there's not too much else to say. My gut feeling is that we won't be doing too much intervening on asymptomatic stenosis in the future, as has been hinted already. And I think the reason for that is, as has already been hinted, that medical treatments have got better. This is just the overall risk of stroke or TIA, or overall risk of stroke after a TIA or stroke in Charles Warlow's Oxford Community Stroke Project versus our Oxfam study in the same population. And it's come down quite a lot over that period. It's now come down even further in the second 5 years. It's somewhere about here. So the medical treatments do work. We are getting a hold of stroke, and we are preventing it mainly with medical treatment and other things, stopping smoking. We've seen these sorts of analyses. It's the same for asymptomatic stenosis. The natural history is now a lot more benign. Here's Hugh's ACES study, our study, Dave Spence's study, the SMART study that we heard about earlier. It's becoming a very consistent picture. The risk of stroke is less. We've followed up our cohort a little bit longer now, and we found that things haven't changed. It's still small. It's still just 500 patient years. These are people with asymptomatic carotid stenosis. Only 3 ipsilateral strokes over those years, and none of those were disabling. None of them were fatal. There were 48 deaths over the same period, and 2 of those 3 strokes, the patients actually had atrial fibrillation, and that was probably the cause of their stroke rather than the asymptomatic stenosis, or it's certainly a possibility. So that when you're on statins and other medical treatment, the prognosis is very good in the vast majority. There might be a small group identifiable by microemboli and by imaging, as Hugh and others have shown, that might be worth still thinking about, but the prognosis is getting rapidly better. The only thing that I see as an indication for endarterectomy and asymptomatic, so I think, is blood pressure. As a group, we've become very interested in recent years in blood pressure variability. Patients at risk of stroke have incredibly variable blood pressure. They have a lot of peaks and troughs, and that variability itself predicts stroke. Most of that seems to be the peaks. It's the maximum blood pressure which seems to induce stroke. But sometimes there are patients where hypotension induces strokes as well. And it's mainly in people with occlusive disease, often occlusive disease of the vertebrals or the basilar, as we've heard, but also people with bilateral carotid disease. But the interesting thing about it is that you actually need this level of severity of carotid disease, bilateral severe stenosis, or more commonly an occlusion plus a severe stenosis, to really have a hemodynamic problem. When we looked at the old endarterectomy trial data and looked at the risk of stroke on medical treatment according to blood pressure level, and looked at the impact of stenosis on those associations, so this is increasing risk of stroke. If you've got, if your blood pressure's high, the stenosis has less of an effect, interestingly, on the stroke risk. So part of it is probably hemodynamic. As the blood pressure comes down, it's really only people with bilateral severe stenosis that get any hint of increased stroke risk, and it's only really people with systolic less than 130 consistently who have bilateral stenosis greater than 70% that have an increased risk of stroke. And I think this is probably likely to be the case in asymptomatics as well. These were mainly symptomatic patients. But there is an argument, I think, for someone who's got troublesome blood pressure, they're having troughs, that endarterectomy may be more effective for asymptomatic stenosis in that situation. But it's a small subset of people with bilateral severe disease that we're talking about here. So to finish, just about on time, we know a lot more about the past. I think there are enormous lessons that we can learn about how we go forward in the future, and the working together of neurologists and surgeons, I think, has been incredibly valuable. The present we know a little bit about, and as illustrated by the session this morning, there are a lot of unanswered questions. And I think the future is still uncertain, but as far as I can see, in terms of endarterectomy versus stenting, for example, the future is endarterectomy. And I think the future is mainly symptomatic stenosis, but we have to intervene quickly to get the benefits. And I'll stop there. Thank you very much.
Peter, thank you very much indeed. I'm sure you appreciate from the applause that's gone down very well indeed. That's a superb overview of where we've been, where we are, but perhaps more likely where we might be going. I think the message here is that these large trials where we go across the disciplines are the ones that have really answered many of the questions. And maybe that's a very important message for everyone to take home. So on behalf of the College and indeed the Vascular Society, may I thank you very much indeed for this excellent lecture, and it's my pleasure to give you this year's Kinmonth Lecture. Congratulations. Thank you very much indeed. Thank you. Hope you're pleasure.
So before you all disappear and head off back home, I'd just like to introduce Dave Burridge, my colleague from Leeds, who's now become the president of the Venous Forum, and we'd like to hand out the prize. David.
Thank you very much, Julian. If you just bear with us just for a minute or so. I'm very pleased to announce that the winner of the Venous Forum Prize for this year is Mr. Sala Tenner. I hope he's still here. Mr. Tenner's presentation was entitled, "Have we reduced the prevalence of leg ulcers?"